Okay, good evening, everybody. Welcome to our Wednesday Wellness for Women. We are going to go ahead and get started. Just another reminder for those who were signing in at my last announcement, your cameras are off and your microphones are muted. This is intentional. It is to allow for a smooth presentation for both of our providers this evening as they work through their slides. We do have time set aside at the end for questions. If you do have questions that come up throughout the event, if you could please just type them into the chat and we will work through them at the end. So I'm going to go ahead and introduce tonight's event with our first provider. So Dr. Theoharis is joining us from Rochester Hills Obgyn, and he is going to go ahead and speak with you about abnormal uterine bleeding. So I will let him take it away, and then he will introduce our second provider this evening. So Dr. Theoharis, welcome, and thank you for presenting tonight.
Thank you, Kelly, for the opportunity, and thank you to everybody who's taken time out of their schedule to join us this Wednesday. Tonight, oh, I can't control my slides, Kelly. There we go. Tonight's topic will be abnormal uterine bleeding. We're going to discuss a little bit about the evaluation and the management options associated with that. My name is Evan Theoharis. I'm a physician at the Rochester Hills OBGYN office. I'm the site medical director, and we have a focused practice in minimally invasive gynecologic surgery. We're a designate by the American Board of OBGYN, and I will discuss what that means a little later in the talk. A little introduction about myself. I'm a Hoosier. I went to Indiana University School of Medicine. I graduated from IU as an undergrad, went to the university in Indiana. When I completed that, I came to Michigan State University, the Sparrow Hospital OBGYN residency program, and graduated in 1995 from there. And it's where I met my wife during my residency, and she was a nurse at Henry Ford. And so that's why the next segment comes into play. I became a senior staff member of the Henry Ford Health System at West Bloomfield and was there for about a quarter of a century, a little more. While I was there, I served several roles. I was an associate OBGYN residency program director. I was an associate director of a minimally invasive gynecologic surgery fellowship under the directorship of my esteemed partner, Dr. Eisenstein, who you will hear from after me. And most recently, I served as the service chief of women's health at the new West Bloomfield Hospital. For reasons beyond the scope of this talk, Dr. Eisenstein and I decided to make a transition, and we currently are IHA physicians, excited to be part of the IHA family. We are located in Rochester Hills, and there's a picture of some of the frontage of our office. We are affiliated with the St. Joseph Mercy Oakland medical staff, and we're located on Auburn Road, and the phone number is bolded there for you to write down if you'd like. We are a full-service, patient-centered obstetrics and gynecologic practice. We see all women of all ages for whatever gynecologic condition they may have. We see high and low risk of obstetrics and gynecology patients, okay? So even though we're talking about abnormal bleeding and we're talking about gynecologic issues, and we do have a focused practice in minimally invasive gynecology, we are a full-service OBGYN office. We are accepting new patients. And I want to briefly just discuss what a focused practice in minimally invasive gynecologic surgery means. It is a new designation by the American Board of OBGYN. This is the board certification wing of our specialty that has created a designation to set practices apart from other practices. And it demonstrates that we have shown competence both in a written exam and in our clinical clinical cases that we have performed a certain number of cases of different complexities and have passed a written exam, which we're both very pleased to announce that we passed last month. So we're excited to have this designation. In fact, I believe we are the only two providers on the St. Joseph staff that have that. We may actually be the only two in Oakland County, and there is one other physician within the IHA network in St. Joe's, Ann Arbor, who also did receive this designation. Tonight's topic is going to be abnormal uterine bleeding. Basically, this is a very common problem that affects all women of all ages. We're going to talk a little bit about the definition of abnormal uterine bleeding. We'll talk about the evaluation and then discuss the management options. What is abnormal uterine bleeding, or AUB as it's commonly referred to? You can find many definitions. Different organizations have their own criteria on how they define it. And in general, it's bleeding of abnormal quantity, duration, or schedule. But in my opinion, abnormal bleeding is whatever you think is abnormal. So it's a very individual diagnosis or problem. For today's talk, we're going to make an assumption that the condition is going to, abnormal bleeding will be in premenopausal women of reproductive, in the reproductive age groups. If we discuss postmenopausal bleeding, then any abnormal bleeding needs evaluation. So uterine abnormal bleeding can be a one-time episode that may require something as simple as keeping a menstrual calendar. But if you're postmenopausal, any bleeding at any time requires immediate evaluation. That is a whole separate talk, but for today's purposes, we're going to assume that your reproductive age group, premenopausal abnormal uterine bleeding. During the initial evaluation, we first need to make sure that you're stable as far as your hemodynamically stable, it is. If you call the office and you're saying that you're bleeding excessively, we want to make sure that you're not feeling lightheaded, passing out, or need to be seen in the emergency room to get either IV fluids or a blood transfusion. For the sake of this discussion, we're going to assume that you are hemodynamically stable. And so we're going to start off by taking a very lengthy history in the office. We'll ask you questions such as how long have your periods been abnormal? How have your periods been for the past 3 to 6 months? We want to establish kind of a baseline of what's normal for you. How many days are in between your cycles from the first day of one period to the first day of the next one? How long does it last? Is it heavy, regular? Do you spot in between your cycles? All these things give us clues as to what may be going on. Is there pain associated with your period? Does the pain go away when your period ends? Do you have pain when you're sexually active? Do you pass clots? Do you have to wear dark pants during that time of the month? Is it a social problem for you? Are you sure it's coming from the vaginal area? Could it be coming from the rectum or the urethra? We're going to ask you about your sexual history to see if there is a chance of pregnancy, or even perhaps what your risk of infection might be. We also want to know if you've had any prior gynecologic surgery, such as myomectomy or cervical surgery for abnormal pap smears, or if you've had previous cesarean sections, as all those things can contribute to abnormal bleeding. We're going to also ask you about contraceptive history. As you may or may not know, all contraceptives can cause abnormal bleeding. They can cause your periods to stop, or they can cause them to become irregular. And then we're going to go over any risk factors that you may or may not have for any type of gynecologic malignancies. We're then going to kind of take a deeper dive into your medical history and do a thorough review of your medications, as there are many medications that could contribute to an abnormal bleeding pattern, either with heavy bleeding or making a situation where you may not have a period at all. We'll investigate whether or not you have any bleeding disorders, such as von Willebrand's disease or any other clotting disorders. We will look for any type of endocrine disorders, such as thyroid disease, prolactin disease, or a host of others. And we'll look for any other medical conditions that could contribute to an abnormal bleeding pattern. The next step would be the physical exam, where initially we're going to examine and look for signs of systemic illnesses, bruising. We'll examine your thyroid to see if you have an enlarged thyroid, any abnormal hair growth, acne, any breast discharge, just to name a few. We'll then move towards the pelvic examination, where we'll examine different sites of where the bleeding could be coming from. It could be coming from the bladder, it could be coming from the urethra, it could be coming from the rectal area. If those are the cases, or if you've had a change in bowel habits, that may need immediate evaluation by another specialist. We'll see if you're currently bleeding to see the quality of the blood flow. Is it dark blood? Is it red? Is it heavy? Is it light? We'll do a bimanual exam, as you can see the picture on the right there. We will try to feel the size and shape of the uterus, try to examine the ovaries and see if they are enlarged or not. See if our exam elicits any pain, look for any pelvic masses. All those things give us clues as to what may or may not be going on. Once we've once we've completed the initial evaluation, we then move into the secondary evaluation, where this will consist of a host of laboratory tests, imaging, okay, and then finally an evaluation of the endometrial cavity. The laboratory test will include first and foremost a pregnancy test, and yes, we will do a pregnancy test even if you tell us that you're not sexually active. Even if you tell us that you're on birth control, we will still do one. I cannot tell you how many times a pregnancy test has come back positive, and we were assured that there's just no way that this could have been the case. A blood count will be drawn. A blood count gives us a lot of information. It tells us if you are anemic or not. It tells us what your hemoglobin level is. It indicate perhaps if there's a risk of infection if you have an elevated white blood cell count, or it could tell us a little bit about your clotting profile when we look at the platelets. Often we obtain hormone levels to see if that could be the cause of your abnormal bleeding. Ovarian hormones, estrogen, progesterone, the follicle stimulating hormone, the LH, the prolactin, the thyroid, all of these could be abnormal and cause bleeding patterns that are abnormal. These indicate some pituitary issues, ovarian function, ovarian reserve. There is also investigation of the adrenal gland and of the male hormones such as testosterone that can be ordered. We'll also look at coagulation profiles. As I mentioned, von Willebrand's disease is a common condition that affects about 1% of the population, which could present as chronic heavy bleeding over the long term. We'll then move into imaging techniques, and the gynecologist will often order an ultrasound. This is really the first line of imaging. It's the treatment of choice. It's the imaging of choice for us, and this can be done with a transvaginal or a transabdominal and transvaginal approach, with or without saline infusion. And that's where they put a little bit of saline inside the lining of the uterus to help look at the architecture of the lining of the uterus to see if there are any polyps or fibroids. If the ultrasound suggests any further need for evaluation, the next level of imaging would be an MRI. And you can see there's a picture of an MRI machine on the right. What we're looking for are polyps and fibroids. Sometimes we use the MRI to map out the fibroids if it's thought that you're going to have a procedure that would call for the removal of the fibroids. Adenomyosis, that's a big word, but all that means is the lining of the uterus has begun to invade itself into the wall of the uterus, and this can cause kind of a spongy and boggy appearance of the uterus and can cause discomfort and some irregular bleeding. Endometriosis, although may not be seen on ultrasound very easily, but sometimes can be seen on MRI and certainly can be felt on exam. We also want to look at the ovaries to look for any masses or cysts, and look at the tubes to see if there's any evidence of infection. Once we've completed the imaging, we move into the endometrial evaluation, where it can consist of a simple endometrial biopsy that's done in the office. Again, as I mentioned, saline infusion ultrasound can be performed to help look at the architecture of the endometrium. And what I'd like to focus on is what we commonly do in our office, and that is disposable office hysteroscopy with endometrial sampling. And we use the EndoC procedure. We found that this has really streamlined our workup. Endo, see, as you can see, there's a little picture of it. It's a little small handheld device with a small catheter, about 3 millimeters. It's done in the office. It's very easy to perform. There's really no preparation needed. It's essentially pain-free. We ask the patients take an ibuprofen or Tylenol before they come in. The information that we get is immediate. I can take pictures of the lining of the uterus. I can show you the fibroids. I can show you the polyps, or I can show you that there's nothing going on inside. And I can take a little video clip and put that as part of your record. What it does is it allows for the physician to properly plan what procedure you may or may not have. If we see something inside that can be easily removed, then that'll be the appropriate procedure. If it looks like there's nothing inside, then that may call for a different procedure. There's no IV required, no sedation, and you can drive home by yourself. You don't need to have a driver come with you. You can drive home from the office, and it's very tolerable. So now that we've completed the evaluation, the history, the workup, the laboratory, the imaging, the biopsy, what are the next steps? What are your options at this point? Well, our philosophy is we like to start out with the least invasive, the least risky option first, and then move on from there. So if everything has checked out fine, or we have found a condition, let's say, for example, you have a thyroid condition, we will treat that. But if everything is okay, the biopsy is normal, the ultrasound looks good, observation is certainly an option. Okay, you don't have to have anything done if you're okay with it, and we've ruled out anything ominous. If observation doesn't work for you, you can then move to the next level of medical management, and that would include things like birth control pills, not for contraception, but there are a lot of non-contraceptive benefits of contraceptives, and controlling of heavy bleeding is one of those. On the right there, you'll see that there is a progesterone-containing intrauterine device. This is a very easy procedure to put into the uterus in the office, and it has excellent control of bleeding. In fact, most women will stop bleeding altogether. There may be a little bit of spotting, but certainly this is equally as effective as having the surgical procedure of endometrial ablation, which we will discuss probably in the next slide or two. And then if medical management fails, or if that's something that you're not interested in, then we can always escalate that to surgical management. When we talk about surgical options, we have the hysteroscopy, and hysteroscopy basically is a word that means looking inside the uterus, and resection means just removing anything that should not be there, or ablation means burning or destroying the lining of the uterus, and we'll talk a little bit about that and what I mean by that. There's also myomectomy, which is removal only of the fibroids, which can be done for women who want to preserve their childbearing. And that can be done in a robotic, laparoscopic, traditional open, or a technique that Dr. Eisenstein and I have started doing quite regularly with the mini laparotomy, and I'll discuss that in just a few moments. There's also a technique called uterine artery embolization. This is done by another specialty. This is done by radiology. This is where you have through the groin, much like heart catheterization. Instead of catheterizing the heart vessels, they catheterize the blood vessels to the uterus, and they plug those blood vessels with polyvinyl chloride pellets to starve the fibroids of the blood supply so that you become less symptomatic. And we'll discuss that a little bit more as well. Now, there is a procedure that I will just mention and name, but won't discuss it in detail at all because I don't want to steal anything that my partner, Dr. Eisenstein, will be talking to you about, and that's the assessive procedure. That's radiofrequency ablation, and that will be the focus of his talk. Ultimately, if none of those other options work or they are not appropriate for you, we have hysterectomy. And I want to briefly talk about hysterectomy and some of the misconceptions about that. First of all, it can be done laparoscopic, robotic, vaginally, or open. Hysterectomies in this day and age are not done the same way as they were 10, 15, even 20 years ago. The first thing we talked about in the previous slide was the hysteroscopy with resection or ablation. On the left, you'll see that there looks like a small fibroid in the lining of the uterus, and there is a metal piece of equipment there. And I'm not sure if many of you are old enough to remember what a Pac-Man was, but the Pac-Man video game used to gobble up the little dots on the screen. Well, we kind of analogize that to the Myosure resection that kind of gobbles up the fibroid or the polyp that may be inside the lining of your uterus. Very effective, very easy to perform, very quickly, and it's an outpatient procedure, and the recovery time is minimal. If for some reason we find in the office evaluation that you don't have any polyps or fibroids, but you still are having problems with heavy bleeding and you didn't want to have an IUD, or the IUD didn't work for you, or medications didn't work for you, and you wanted to have an ablation, we typically will use two types of ablation. One is the Novosure, which I use most of the time, but there's also the hydrothermal ablation, where hot water is raised to a temperature that will cause a lot of heat to the lining of the uterus to essentially scar the uterus. As you can see, the probe goes inside the uterus, it takes the shape of the uterus, we apply energy, and it knows how deep to burn the lining of the uterus to create a scar so that your bleeding either becomes absent or is really minimized to spotting. It's about 90% effective and very tolerable, again, sometimes with very little recovery. In fact, one of our office managers in my previous practices had it one day and was at work the next. Okay. This is just a picture of what hysteroscopy looks like. You can see the top picture is a very normal, fluffy endometrial lining, no polyps or fibroids, very normal cavity. This was a lady that was operated on last week. Took a picture before the ablation, and as you can see, we then did the Novosure, and you can see the difference of the ischemic effect. Ischemic, or we can see where it's basically burned, and so that will cause some scarring, and she will have very little bleeding from the uterus. We mentioned uterine artery embolization. Again, it's performed by radiologists. Not everybody is a candidate. As part of the workup, you will need an MRI and an endometrial biopsy. You will need to look at the number of fibroids, the location of the fibroids, and depending on where those fibroids are and how many you have will determine whether or not this is a procedure that would be offered to you. It does usually require an overnight stay, and it's about an 85%, has about an 85% effective rate in reducing any symptoms that may be associated with your fibroids. Now I just want to briefly talk a little bit about myomectomy and hysterectomy and what advantages minimally invasive surgery may have. The image on the left shows traditional incisions that are made for either myomectomy or hysterectomy. You can see that if the fibroids are big enough, or if the uterus is big enough, you may end up with a big midline incision. You may know people that have these kinds of incisions. Then you may see some cesarean sections that were performed with a little transverse incision down below, and we often do surgery through that as well. But this is kind of, this is only if we cannot do minimally invasive surgery. And the picture on the right shows the little keyhole incisions that we can operate through when we want to perform either myomectomy or hysterectomy. Again, small keyhole incisions. The advantages are less pain, less infection, fewer complications, quicker recovery, and frequently, more often than not, this is a same-day procedure where you are home later in the afternoon. It's not very common that we keep patients overnight. If we had to do the incision like the image on the left, that would require at least a 2, sometimes 3-day stay. And of course, there's less scarring. One of the topics that people may be a little uncertain about is when they hear about their procedures, like somebody had laparoscopy or somebody had robotic surgery, and really what's the difference? So I'll just briefly explain. We are both laparoscopy doctors. We perform laparoscopy, and we are both trained in robotics. So that's me on the left sitting at the robotic console. The patient is in the middle of the room, and we are connected through a series of cords and wires, and you can see that I'm sitting down. It's very comfortable, ergonomically pleasing to the surgeon, and the control of the instruments is very steady. You don't have to depend on another person holding the camera, so there's no tremor involved. When I look inside that box there that says Da Vinci, I'm looking at a 3D image as if I'm immersed inside the pelvis of the patient. If you look at the patient, if you look at the image on the right, that doctor is turning his head and looking at a 2-dimensional version on a flat screen monitor. And over time, that can certainly wear on the surgeon's neck. And he's holding the instruments with his hand. And it doesn't show this, but somebody else has to hold other instruments in the camera, and it can be a little bit shaky at times. And although we both do laparoscopy, some people prefer it. I prefer the robotic approach. I've made it a career decision that I focus my practice on minimally invasive surgery and robotics. I find that you can do far more difficult cases with the robot with a lot less risk of having to convert to an open case. So cases that we traditionally would have had to perform traditional surgery on, we can now tackle with the use of the robotic instrumentation. Dr. Eisenstein also does straight stick laparoscopy and is quite competent at performing very complex endometriosis cases with both the robot and the straight stick laparoscopy. When I say straight stick, I just want to give you, I usually describe trying to tie knots if you extended your arms straight without being able to flex your elbows or your wrists. That's what traditional laparoscopy does. The robotic would be if you could loosen your wrists and move them and tie a knot. That's the way the robot functions. So there's a lot of degrees of freedom within the arms of the robot that allow you to perform surgery in a more natural way. Now there is the issue of cost, and the argument could be made that the upfront costs with the robot are expensive and the equipment is expensive, but nonetheless, robotics is here to stay and it's continuously improving. So why choose OBGYN or Rochester Hills OBGYN? Again, as I mentioned early in the presentation, we are a focused practice designee from the American Board of OBGYN. We're quite proud of this accomplishment. Between the two of us, we have over half a century of experience and thousands of MIS procedures performed. We either perform these cases individually, but frequently we operate together and we work well together. We've been partners for more than 25 years. And so not only are we professional partners, but we're very good friends as well. What we will do is individualize your care and make every attempt to offer you a procedure that will minimize your risk and achieve the goals and outcome that you're looking for. This is not cookie cutter medicine. Every patient is individual and all the goals are individualized, and there are more ways to do things than just the traditional ways that you may or may not be exposed to if you see other physicians. We can offer you options that perhaps others may not. And with that, kind of transitions nicely into a newer technique that we can offer you that Dr. Eisenstein, who, like I said, has been my partner for over 25 years, came together from Henry Ford. We'll be talking to you about the Assessa procedure. And with that, he is the director of minimally invasive surgical fellowship that will be coming to the St. Joseph Mercy Oakland area. Thank you all so much. I appreciate your time.
Thank you, Dr. Theoharis. So we will go ahead now and welcome Dr. Eisenstein. He will be speaking with you about options in treating fibroid symptoms.
Good evening, everyone. I'm David Eisenstein. A pleasure to be with you. I'm going to now switch our slides to right. Give me one moment, and we'll get to that. There we go. I'm going to close that. There we go. And let's see. Let's see. Kelly, are you seeing my slide set now?
I am. Go ahead and put it in presentation mode.
There we go. Very good. Again, good evening. I am David Eisenstein, and I am also American Board of OBGYN designate in minimally invasive surgery. And Dr. Theoharis and I previously ran minimally invasive gynecologic services at Henry Ford. And we're bringing those services to St. Joe Mercy, Oakland, and the IHA Trinity family. My background is I am a University of Michigan graduate, did my residency in Washington, D.C., and for the past 20 years have focused practice on chronic pelvic pain, endometriosis, fibroid treatments. And Dr. Theoharis and I were one of the first people to do robotic surgery in gynecology in the state of Michigan as well. So that gives you an idea of our background. I'm going to talk to you about treating fibroids, and most specifically treating fibroids with a newer technique known as laparoscopic radiofrequency ablation, sometimes known by its trade name of Acessa. To set up the talk, I do want to comment on a couple of concepts as background and context. You heard Dr. Theoharis talk about minimally invasive surgery. Sometimes you will see the acronym MIS in various contexts to talk about this kind of surgery. So what does that really mean? And Dr. Theoharis talked to you about that, about different instrumentation, technical approaches, technology. But you know, when over the years, when patients as consumers of their healthcare come and talk about these options, there's a lot of different impressions that people may bring with them into consultation. And these are some of the phrases that patients have used with us over the years, going back 2 or 3 decades. Laser surgery, robotic surgery, that belly button surgery, keyhole incision surgery, that surgery that will give me faster recovery, same-day surgery. And all of these concepts are present in this idea of minimally invasive surgery. And nowadays, probably the most common impression of what constitutes MIS does use the Da Vinci platform, so-called robotic surgery, which is very prevalent nowadays. But I'd like to argue that what we're trying to provide for you when we talk about MIS is maximally impactful surgery. In other words, we want to be very patient-focused. We want to be focused on both goals and outcomes. So to my mind, I don't like getting too caught up in any particular technology, but use the right procedure at the right time for the right reason in the right patient. And these are conceptual frameworks that I hope that when we sit down with you as a patient, we bring into that consultation so that what we deliver to you is high quality, high safety, and very impactful for your health. This is a cartoon I use a lot in lectures. You just see surgeons around a table, and one of them is pulling out a porcupine and is saying, well, I guess that explains the abdominal pain. So we don't want to be porcupine surgeons. We want to have very focused on what we are looking for and what we are going to do for you. So that's a little context about talking about surgical sensibility and mentality when we talk about procedures with you. We want maximal impact surgery. When it comes to fibroids, common, anywhere from 50 to 80+% of patients. So very common, undoubtedly, within this audience, either yourselves or people you know have had a diagnosis of fibroids. They are generally thought of as non-cancerous, not malignant, tumorous growths. It often can be confusing to hear a word like tumor and not associated with cancer. But fibroids, we don't really talk to patients when we're describing fibroids as being something of danger to life and limb per se. There can be a rare cancer in fibroids, and we can get into discussion of that in the Q&A if you'd like. But in general, when we diagnose fibroids and we're connecting those fibroids to issues such as pain or bleeding that you're having, the context of the conversation is not going to be that this is cancer. Although part of our responsibility as part of your workup is definitely to make sure we don't miss such a diagnosis. And I think that was evident in how Dr. Theoharis described how we work things up to make sure we get ultrasound images, to make sure we get biopsies of appropriate areas, to make sure we know what we're dealing with when a patient has bleeding issues. Now, I like to say that fibroids are kind of like real estate because it matters what portion of the uterus that they generally take up, because they can grow inside and outside the uterus. And common terms you might hear referring to that include submucosal or intramuscular or serosal fibroids. And when it comes to the kind of issues associated with fibroids, a lot of women may have fibroids and no issues whatsoever, no symptoms. And then there's a range of other things that we can rightfully blame on the growth of fibroids. Pressure in the pelvis, pressure on the bladder that can either cause you to have to go a lot or even get in the way of completely emptying, depending on the size and location. Obviously, the abnormal bleeding issue has been a focus of this talk. And there can also be issues with pregnancy. That latter issue makes it even more complicated because plenty of women can certainly get pregnant and have fibroids and have a normal pregnancy and have a normal delivery. On the other hand, there are times when fibroids, depending on location, might get in the way. So here are a couple of cartoons that may help give an impression of when I say location, what we're talking about. On your left is a cartoon version of the classification of fibroids that is based on where they're growing. So for example, the type 0 are fibroids that sit directly inside the cavity where the menstruation fluid comes from, where a pregnancy would be carried. And then as the fibroids grow a little more and a little more and a little more into the wall of the uterus, we classify them accordingly. Types 0, 1 are in the cavity, 2 are starting to grow more into the wall of the uterus, and etc., as you can see in this cartoon. And on the right is a medical drawing that gives a more realistic picture of what these fibroids actually look like in terms of size and shape corresponding to these different types. And depending on where and how big they are, will determine what kind of treatments are appropriate for you. So, a common reason we might see a patient come into our office is that they're looking for choices that perhaps in prior consultation may not have been offered or talked about with the patient. So this kind of question is a common one, I would say, in both Dr. Theoharis and mine experience when patients come and want to talk to us about what's going on. Do I need a hysterectomy? Well, the answer to that is decidedly no. The only thing that is totally mandatory about your options is that you need a thorough evaluation of the situation and partnership with your provider on what your personal goals are in your health care. That is how we develop a treatment plan that's going to be safe and effective for every patient. And so those decisions on even doing any kind of procedure are going to be according to your individual needs as a patient. There are really no have-tos. I think it's very rare that we should say, oh, you should or have to do this or that procedure. Because as you can see on the right, and again, this just overlaps with what Dr. Theoharis talked about, your options when you have symptomatic fibroids, abnormal uterine bleeding, pain, etc., range from observing the situation to a range of medical options, and then there are various procedures, and Dr. Theoharis went over all of them. So if we're going to do a procedure for you, how do you choose? What procedure do I choose? Well, you can remove the uterus, as we talked about, and there are different surgical techniques to do that. Removing the uterus, obviously, is called a hysterectomy. We can remove the fibroids. So we're going to spare the uterus, take the fibroids out of the uterus, and repair the uterus so that you are intact. And obviously that allows for the potential for future carrying of pregnancy, but it's also for patients who simply don't find that taking their uterus out is part of their goals. And there are the different surgical techniques that Dr. Theoharis described. And then you can treat the fibroids right where they are. And this in italics is the radiofrequency ablation, which I'm going to talk about further. Next to that is uterine fibroid embolization. That is a different procedure. Dr. Theoharis described it somewhat. And it's an interesting contrast between these two options to treat the fibroid in place. I'm not going to get into the comparison and contrast too much, but in the Q&A, perhaps would be a good place to talk about that if we'd like to. So laparoscopic radiofrequency ablation of fibroids. What is this? Well, if we break down the title of this, laparoscopic, this means the surgical technique we're using to do the procedure. Laparoscopy meaning getting access to the inside of your abdomen through small incisions, generally from a quarter to a half inch. We talk about centimeters, so it's 5 to 10 millimeters or a half to 1 centimeter. But it is a laparoscopy, so you're put to sleep. It's in an operating room. We fill the abdomen with carbon dioxide gas, which is a safe and non-reactive gas that's used for laparoscopy. And we look inside the abdomen to visualize things. Radiofrequency. This is a type of energy. The energy comes in waves at the same wavelength as your radio. And this is the wavelength that has been used for surgery for 100 years, what we call electrosurgical energy. So the procedure of ACESA or laparoscopic radiofrequency ablation uses that wavelength of energy. Then ablation. Ablation is a general word, and it means destroying tissue by heating it up to a temperature above which cells and tissue cannot survive. So ablation is applied to a whole range of different situations in different specialties. So it's a general term. In gynecology, we've introduced already the term endometrial ablation, and many of you may already be familiar with it because it's a common procedure done in doctors' offices and in operating rooms in a lot of places. And that is heat that is destroying the interior lining of the uterus so that you won't have very much bleeding or none at all. And here we are applying this to fibroid tumors. So what exactly is it? So here we have, again, a kind of cartoon picture of what's happening with radiofrequency ablation. On the picture, the patient is obviously on the operating table. Her legs are to the left, her head is to your right. There in the middle, through the belly button, there is a scope and camera enabling the surgeon to see inside. Right above the uterus is another tube that gives us entry into the abdomen. And through that tube is an ultrasound probe. So the camera is looking at the uterus. So that's the smaller picture at the bottom. The probe is placed against the fibroids in the uterus, and we get ultrasound pictures of the fibroid. Using those ultrasound pictures, the ACESA handpiece, or the RF ablation handpiece, goes right through the skin because it's a 2.3 millimeter needle and is guided into the fibroid. So we treat the fibroids via the heat that needle will provide, and it has great safety as a procedure. A paper that I authored with colleagues came out last year, even looking at people just starting to do this procedure. The complication rate is extremely low. So the steps in doing the procedure are doing the laparoscopy, so safely entering your abdomen after you've been put to sleep, looking at the fibroids, using the ultrasound probe to get a picture of the fibroids by ultrasound. Then after we visualize them, step 2, we guide the handpiece into the fibroid. And then while that handpiece is in the fibroid, prongs come out, and then we heat up those prongs with radiofrequency energy, which then transfers heat to the fibroid. And this heat you'll see in the next slide, it gets up there in terms of anywhere from 60 to 90 degrees Celsius, which kills the tissue in the fibroid. And what's unique to this procedure is that the tissue effect is isolated to the fibroids. The surrounding uterine muscle is not affected by this. And then once you're treated, you complete the laparoscopy. So what happens to the fibroids when we do this to them? Well, we take a firm tumor, here the example is a baseball, and we immediately soften it by what we've done with the heat. I would argue more than a marshmallow, the consistency of fibroids when you've done this to them is more like silly putty. And then you're going to find that the surrounding tissue is going to absorb the fluid that was in the cells through basically mist or heat, and the fibroid is going to start shrinking. And then the symptoms from that fibroid shrinking will follow the shrinkage over the next several weeks, will get better. So this is an example what happens when we heat up the Acessa handpiece. So here it's just been in the fibroid and it's deployed. You can see the color coding to the right, and this is in Celsius. And so as it turns on, you can see how it heats up. And in the center of this, it gets very high, up to about 95 degrees Celsius. And then the temperature tails off a little bit as you get further distant. But even a couple centimeters away, it's at the 55 degrees, which is going to effectively treat the fibroid tissue, which will render it inactive, softened, and it will shrink over time. So exactly what happens to the fibroids? On average, you get about 45% decrease by volume. Now that's going to depend on many characteristics of each fibroid that you treat. Is it very dense? Is it less dense? Does it have a high water content? It also will depend on how effectively you can get into every nook and cranny of the fibroid. Because as you may remember from the cartoon medical drawing, fibroids are different shapes and sizes. They're not necessarily an exact sphere. In fact, they are rarely an exact sphere. So these cartoons will show you what anywhere from a 25 to 75% reduction will give you in terms of size. But the key to the procedure is that it's both size and consistency and also inactivity, that these fibroids are changed from an active, very firm tumorous tissue to an inactive, compact sort of plug of proteinaceous tissue. So the next question is, really, who should consider this as an option? You may remember earlier in the talk, I said that size and location are all factors in what is a good idea for any particular patient. So first of all, the patient who's a candidate for this procedure has been evaluated fully, and we find that she has symptomatic fibroids, meaning it's not just because she has fibroids, but because the fibroids are clearly underlaying the problems that we're seeing: abnormal uterine bleeding, pelvic pressure, pain, and so forth. So we've evaluated the patient. Number two, the patient has a goal of maintaining intactness. She wants her uterus. For whatever reason that might be. It doesn't necessarily mean pregnancy. It can mean that you're 46 but are not interested in hysterectomy as your approach. I have a rule. This is my rule, my 10 by 6 rule. This is not a gospel, but it is a guide I use toward appropriateness of the procedure. My 10 by 6 rule means that the best candidates for an Acessa procedure have fibroids no greater than 10 centimeters and generally no more than 6 fibroids. Now, I've certainly treated patients who've had some bigger fibroids than this and more numerous, but this is a thumbnail guide. And the reason I use this guide, it's based on my experience of treating patients over the years, has to do with good outcome and also surgical safety. Because once you get to be treating a more numerous and bigger fibroids, the amount of time the procedure takes starts going up. And we know that once you pass 4.5 hours in the operating room with fibroid therapies, complications do start creeping up. So I want a safe, effective procedure for you as a patient, and this is my rule of thumb. There are real experienced people around the country who do this procedure, particularly the gentleman who invented this, who has the wonderfully evocative name of Dr. Bruce Lee, and he's in the LA area. He will be pretty aggressive about the size and number he can treat. Personally, this is the niche of patients I recommend for this procedure. Something also to know that in the medical literature describing this procedure and its outcomes, the procedure is described in patients whose overall dimensions of their uterus are about 4-month pregnancy size or less. That type of size fibroid is one that you might feel just below your belly button. So this gives you an idea of the candidacy. Also, fibroids that are either hanging off the uterus by a thin stalk, which is called pedunculated in this cartoon, or the ones that are inside the cavity, like the type 0s, are generally not going to be ones we treat with Acessa. There's also the issue of the fertility goals. Currently, the FDA is kind of silent about using Acessa in women who are going to get pregnant in the future. There's lots of good data, however, on successful pregnancy. I've had a couple of patients who've gotten pregnant after this and had vaginal births. But the FDA does want more numbers from us, and those of us who have been involved in the development of Acessa are gathering data for that very reason. So the discussion with you as a patient will have to look at your fertility goals and the pros and cons of this procedure in the context of what your goals are. So what should you expect if you do one of these procedures? It's a same-day laparoscopic procedure, so all patients go home the same day, and you get renewed activity in a few days. One of the early results of the procedure should be a sense of less mass and pressure because we've immediately transformed this tumor to that silly putty consistency. And then over the next 3 months or so, you'll get continued shrinkage and bleeding symptoms associated with the fibroids will resolve. So that is my talk for you. If we have any questions, we are happy to entertain them at this time. Thank you very much for your attention.
Okay, so it looks like we have a couple questions. I'll go ahead and read through them. If you would like to then go ahead and answer, we'll try to work through these. So I'm going to start with the private ones first because we do have two in our private chat. It says, does endometrial ablation prevent growth of future fibroids?
Not necessarily, no. And actually, you can do an endometrial ablation with small fibroids inside the lining of the uterus. However, it does not prevent growth of fibroid. And many times we'll do an ablation with somebody who already has fibroids. You saw the slide by Dr. Eisenstein that shows the different locations. You may have a type 6 fibroid that's on the outside lining of the uterus, but the ablation only treats the inside lining of the uterus. So those may continue to grow. And so typically during the evaluation, we will know if you have multiple fibroids, and perhaps ablation may or may not be the appropriate technique for you at that time. It may be going after most. It would just be an individual decision, but it does not prevent, to answer your question directly, it does not prevent future growth.
As a corollary to that, you can do a combined procedure. For example, if you have a type 0 fibroid and we want to treat that, and you have other fibroids, one can first do a hysteroscopy, remove fibroids with one of the techniques that Dr. Theoharis demonstrated. You can also do an endometrial ablation at that time. That procedure is going to treat the lining. So let's be clear, the ablation being done there is for the uterine lining tissue. It's not going to affect fibroids other than what you might take out from the cavity. But then you can go ahead after that procedure and do a laparoscopy and do Acessa on the fibroids. I have done combined procedures on patients before for that very reason. So endometrial ablation should be understood for what it is. Its goal is to ablate or direct heat to the endometrium or the lining of the uterus, render that tissue inactive to decrease your bleeding. And then fibroids can also be treated at the same time.
And then it says, what if you have fibroids and cysts, and the cysts are on the muscular wall?
The way I would, first of all, the word cyst is a general word, right? So you can have, and by the way, the definition of a cyst is a fluid area that's surrounded by cells within an organ. So you can have cysts in the ovary, and typically in gynecology, when we talk about cysts, that's the most common place we're thinking about is the ovaries. If I'm understanding the question correctly, though, the questioner is saying, what about if there are cysts in the wall of the uterus? Generally, that sort of situation, if the patient has cyst-like growths in the wall of the uterus, that might be something called adenomyosis. And again, I'm saying this based on what I understand the questioner to be asking about. And it should be clear, if you have adenomyosis, which can look cystic on MRI and ultrasound, you don't treat it with Acessa. Acessa is not to treat adenomyosis, it's just to treat fibroids. So that we should make clear about that. And otherwise, cysts could also mean endometriosis. So I'd have to get some clarification from the questioner as to what she understands the condition she's thinking about consists of. There can be cysts in the muscular wall of the uterus. That would be adenomyosis. There could be cysts of endometriosis on the outside. There could be ovarian cysts. But Acessa is not to treat those. Those have to be removed, essentially, to treat.
In regards to ovarian cysts, they're very common, and most of the time, depending on size and whatever the characterization on ultrasound is, we would typically just observe unless they became symptomatic, and most of the time they resolve on their own.
And of course, if there's a reason that a cyst needs to of the ovary is present, and we're planning to treat fibroids, the cyst can be addressed at laparoscopy also. There's no reason you can't address all of the pathology that needs to be dealt with at the time of laparoscopy. The one thing I would say is that typically in that situation, you would probably have to add one or two more pokes, those keyhole incisions, because you'll need a couple more instruments to be able to do that properly. But it all can be addressed at the same time.
Okay. We have a question in here asking if you suggest taking over-the-counter yeast guard tablets for women.
Yeast guard? Is that the lactobacillus containing? I'm not familiar necessarily with that one, but anything if it's something that contains the lactobacillus, I have no problem with that. It's sure if you're having problems with your current yeast infections, that could help prevent that. Sure.
And if that participant has further question or detail surrounding that, we can definitely encourage them to call the practice, make an appointment, or reach out to their PCP also. I have their contact information here. How many fibroids can be taken out using Myosure, and what size is appropriate?
So Myosure, typically if we're going to do a Myosure, we've already done the office hysteroscopy and looked inside and got a pretty good idea of how many fibroids there are. And fibroids inside the lining may not always be detected to see. If there are multiple ones, you may not see all of them. But I have removed fibroids that have taken up the whole cavity of the lining of the uterus. Now, Myosure is only one technique that can be used to resect fibroids. There's another procedure called using the resectoscope, which is like a hot wire that we can kind of carve out any fibroids or polyps that may be inside the lining, and we would reserve that for more extensive pathology. It also depends on the characterization of the fibroid too. If they're very calcified and very hard, like an eggshell, or if they're very soft and easy to be, resected out, would depend. That would also play into what technique we used as well.
Again, it's individualization. I would say, and I think Evan would agree, when we're dealing with those type 0 and type 1s, generally most patients are not going to have innumerable numbers. Generally, when you've got those, they're 1, 2, 3. They're a limited number is usually what you're dealing with. So there's never a problem of a limit on how many you can take care of. A consideration that we do have to make is size and then time of the procedure, because when you're starting to get to 3.5, 4 centimeter, 5 centimeter fibroids that are in the cavity like that, we do have to be careful about operative time. And I mentioned how complications can go up as time increases. And with hysteroscopy, there are specific complications that has to do with the fluid we use to see inside that we have to pay attention to. So when I'm looking at something like 4.5 centimeters, 5 centimeters, I may not want to go the route with Myosure. But again, that's one of those moments when you're really looking at your workup, looking at your size and number, sharing those pictures with your patient in consultation, and making the best choices for approach. That sort of fibroid, for example, is neither would I do an Acessa on it because it's in the cavity. So that fibroid may have to be removed with laparoscopy, where we cut into the uterus and remove it. That probably would be the safest for something that big. So it's more about assessing the size and number, and how long the procedure might take for safety for the patient.
Thank you. In your practice, have you seen any effect of COVID and or the COVID vaccine affecting the amount of bleeding?
I have not actually had any experience with COVID and abnormal bleeding. Interesting question, though. I think it's a pretty insightful question. I can't answer it, but I think it's a great question. Part of the issue is that if somebody knows they have COVID, if they're having problems, they are kind of diverted out of the office setting and ask, and getting care for patients that have COVID has been kind of a challenge, trying to limit the exposure in the office setting, and they're typically going into the hospital, the emergency room. So I have not seen that, but I think it's a great question.
Now, traditionally, when you look at the history of immunizations, because this has been a hot topic where there's been information about the impact on fertility and so forth of immunizing against COVID, there really is not any data out there for all the traditional vaccines that we give during the lifetime, that they are a problem for fertility and that they are something that impact women's health, sexual health, menstrual health, hormonal health. The theoretical, so for the vaccines we're using, the Moderna and the Pfizer, and the mechanism that they use, there's no real theoretical basis for that technology for why it should mess with you hormonally, mess with your menstrual pattern. But at the same time, there's no real data on that yet for us to make an evidence-based answer to that question. It's clearly something that I'm sure is being gathered from those places where the vaccines have been given and populations are being studied on a large scale, like in Israel. So stay tuned. But it's an excellent question. My personal feeling is that, again, because the history of immunization doesn't seem to be a factor in women's health in terms of what the questioner is asking, I wouldn't anticipate this one would either, but that is, again, a theoretical answer, not one based on practical data.
Thank you. Next question. I had a normal PAP 3 months ago. Lately, day 4 of my period is very painful with a very heavy flow. This past month on day 4, following very bad cramping, I passed blood clots that had multiple small pink tissue clumps in it. Could that tissue possibly be fibroids? At what point would you recommend seeking a medical diagnostic? And thank you for your time and advice.
I'd say now.
It's difficult. I mean, it's probably not fibroids. Usually fibroids don't come out like that, although you can have prolapsing fibroids, but usually they're still attached within the uterus, but they present themselves where they're inside the vagina, where they prolapse through the cervix. But so no, probably not fibroid. A lot depends on this patient's age to see, the severity and like as I talked about, going through her history and her medicines and her previous history, any conditions all come into play in determining, if there is a heightened sense of need for any further evaluation.
Well, I would say, this is a change, right? The way the questioner sets this up, this is a change from her normal. And there's pain, and there's something odd about it. It could be a one-off, but I would.
She should come in for.
Yeah, I would.
It would probably require history. It would require an ultrasound, perhaps, just like what we talked about. Some blood work to see if her heavy bleeding is causing her to be anemic or not. And there's no doubt. Yeah,
I think she should have it worked out.
Thank you. Yeah, she said, age 35, yes, this is a change. She will make an appointment. Okay. Do you perform rollerball ablation? Can Novosure be performed on someone with fibroids?
I used to perform rollerball ablation all the time before Novosure came about. It became very tedious, and the difference between Novosure and rollerball is with the rollerball, it's like mowing the lawn inside, and you didn't have a sense of having consistent depth of burn. with the Novosure technique, it senses the impedance of the tissue and automatically knows exactly when enough tissue has been burned. And so the risk of perforation or burning through the uterine wall is far less. So it's a safer procedure than lower ball. Can you have fibroids with Novosure? Yes, you can, up to a couple of centimeters. They will be treated during the ablation as well. So yes, you can. The real dilemma becomes when we're doing the hysteroscopy, if you have fibroids, is it the fibroid that's causing the bleeding, or is it something that would be more amenable to an ablation? So I try not to do a resection and an ablation at the same time, but you can have an ablation with fibroids. It just depends on the number and, again, the size.
So I'm going to present a somewhat dissenting view from my partner. I'm an old school guy. I got trained in hysteroscopy by some of the bigger names way back when. And so I was approaching these treatments, these ablation treatments inside the uterine cavity before Novosure came on the scene. And I was doing a lot of roller ball and also loop resection, which is where you don't just ablate with the roller ball, but you actually remove swaths of the endometrium down to the muscular layer. I actually am very careful about doing Novosures because depending on associated conditions of the uterus and the age of the patient, there is about a 5% or more rate of what's called post-ablation syndrome, where the patient can have scarring that blocks the flow of any menstrual flow coming out of the uterus that's left after the ablation, and these can be very painful. So there is a modification of ablation of the endometrium that I perform. I call it hemiablation or halfway ablation, and I'll do that with a roller resection. I think that I don't want to get too much into the weeds. I'm talking about these terms because it might be confusing, but how I'll bring home this discussion for the sake of this presentation is that Novosure is a very safe and effective procedure. I think that in the right patient, it's excellent. I think it's better in patients who are a little older toward menopause and who do not have adenomyosis. And I still think there is a real role for those with skills in hysteroscopy, rollerball techniques in certain patients. And so I'll leave it at that.
Okay. Now we're getting a little bit over time, so I'm going to take about 3 more questions. And if we don't get to your question, we'll be sure to review all questions prior to sending out our post-event survey and getting answers out there for you. So next question, in what situation would you recommend an open hysterectomy?
Who goes first?
I think we both would agree that we would make every attempt not to do an open hysterectomy first. There are conditions and there are situations where the uterus is just so enormous that it's impossible to get the instrumentation in to ergonomically perform the procedure. For example, Dr. Eisenstein and I have performed laparoscopic hysterectomies on uteruses that have been well above the belly button, okay? But there have been some that can go all the way up to the liver. And at some point you have to balance the time of the procedure, how long they're going to be under anesthesia versus, the risks of that versus doing an open procedure and getting it done in a little bit more efficient way. I would say that 95% of the time we're pretty successful in doing a laparoscopic or robotic procedure, even with large uteri. But there are still an occasion for an open hysterectomy. And again, it depends on the patient's size, her height, her weight, and how her uterus is in relation to her abdominal wall.
There's also the issue of we're making little incisions, right? So you got these incisions. Well, how do you get something this big out of the patient through this incision? A lot of the time that's done through the opening that's made in the vagina at hysterectomy. Other time that can be done by extending the belly button incision a little bit and disassembling the uterus with a scalpel. But this is also a consideration. If you have a tissue mass that's of a size that you have to start making an incision this big just to get it out, then you have to start asking the question, what is the value of the laparoscopic approach if you're then making an incision to take the uterus out? There's actually a concept called hand-assisted laparoscopy, where an incision like this is made and there's a column device to allow your hand to go in while keeping the abdomen inflated. Again, it gets into the weeds. This is a part of the conversation in the office when removal of the uterus has been decided upon, and it goes back to that flow I described as right procedure, right patient, right time.
What does a fibroid look like if you were to pass one?
Well, this person may have experienced this or know someone who experienced this. Dr. Theoharis was talking about prolapsing fibroid in response to the tissue and symptoms the earlier questioner brought up. But fibroids are generally going to be the appearance of a pale pink. Usually, if it's passing from the cavity of the uterus, it's going to be usually one of the rounder type of fibroids, because it's usually going to be covered with uterine lining tissue as well. So it's going to be usually a smooth, roundish, pale to opaque color kind of tissue. And passing fibroids can be awful because it can be very bloody. Your uterus is contracting because it's opening the cervix. It's like a mini labor. And most gynecologists will encounter over a career a few of these sort of happening. And we've gotten to the point where we can really tell a patient calls up and we know they have fibroids when they're having something like this, what's probably going on.
Rubbery, small, rubbery. They can have different shapes. They can be dark purple. They can be yellow. They can have a hard shell, like an eggshell on them. They can be degenerative. They can be calcified. They take many sizes, right? But in general, they're smooth, firm, rubbery, benign tumors.
All right. I've had fibroids removed 3 times with 3 different procedures. Do you recommend removing them again?
It all depends on your goals and objectives. If you want to retain your uterus for childbearing, or if you have a personal belief in retaining your uterus, then, and depending if your symptoms are due to those fibroids, it's a complete individual case. Now, the issue at hand is 3 prior surgeries probably has caused some scar tissue inside the pelvis, which would make any procedure, whether it's a myomectomy or a hysterectomy, a little more complicated. So there are some risks that are introduced in your situation that you need to be aware of.
To a couple thoughts to add to that. Counseling patients on fibroid treatments. A phrase I use often is that all of these uterine sparing procedures are wonderful. Remember that anything that's short of a hysterectomy is not a hysterectomy. And that's not to try to talk people into hysterectomy, but is to say that anything short of a hysterectomy has a certain rate of recurrence of problems. When you take fibroids out, let's say you do a myomectomy, traditional myomectomy, it has a 20 to 25% rate over 10 years that you'll have problems with fibroids again. And the more fibroids you have, the higher this data. So if you have one solitary fibroid they took out, your recurrence rate is less than the patient who had 7 or 20 or 30, and those had come along relatively frequently. So this questioner, we would look at the prior surgeries, how many they took out, what does the current imaging say, and what are the current symptoms to decide on what would be an approach. And if fertility is not a goal, there are good medications we can use, or you can look at a uterine fibroid embolization as a very minimally disruptive, minimally invasive approach for you.
Thank you. I'm going to take this last question. And again, if we did not address your questions, we'll be sure to review them, the questions, and make sure anything that did not get answered on the call is answered with our post-follow-up survey. And for those of you on the call who joined us this evening, a recording of tonight's presentation will be coming out to you as well. So final question for you tonight. What is the best way to go about diagnosing endometriosis? Can the laparoscopic procedure itself, that is sometimes used to diagnose it, spread the cells or cause scar tissue, potentially furthering the problem?
It's a very good question, because there are cases where operating on endometriosis can allow it to implant in the surgical wounds that you create. This is not too common, but it does happen. Laparoscopy is the gold standard to diagnose endometriosis, and it requires biopsy, because the definition of endometriosis is the type of tissue which we call glands and stroma. The type of tissue that we typically will find in the uterus is growing outside of it, most typically in the deeper parts of the pelvis, the area between your cervix and the rectum, or the area over the bladder or around the ovaries. But the tissue can travel far afield to the appendix, to the diaphragm. It's a very enigmatic, strange disease. Now, ultrasound and MRI in good hands, depending on the type of endometriosis that you have, can also diagnose it. But the diagnosis of endometriosis is based primarily on a good history and a thorough examination, because endometriosis that's kind of invading into your tissues and creating scarring, if you do a careful exam, gentle but thorough, you can typically perceive those scarred areas and have a good idea that that's what's going on. Then ultrasound and MRI can confirm. The one last thought I will say about this is that I am a see and treat sort of person. So laparoscopy isn't mandatory. We can go on our clinical impression and then treat with medicines. But if you're going to go for laparoscopy, I think we should expect and plan that we're going to go in and remove the endometriosis, all grossly visible disease, because that is the best way to get the patient less symptoms and enhance her fertility. We don't want to get her on the road to getting surgery again and again and again. So not just look and diagnose, but look and treat. And then the issue of spreading it around, that's something that, again, we know can occur, that can be intrinsic to the disease. But the mere act of doing the laparoscopy and excising tissue, if it's appropriately done, is not generally felt to be something that will spread the disease.
You did ask about scar tissue. Just in general, anytime you have surgery, for whatever reason, scar tissue it's possible for scar tissue to form. So endometriosis surgery can cause scar tissue. Scarring can be caused by endometriosis. Any surgery can cause scar tissue, making subsequent surgeries that much more challenging.
Okay. Well, thank you very much. We have a final comment here. Thank you for sharing your information and your time with us this evening. So I know that it looks like our participants were very grateful for your information that you were able to share with us.
We were very grateful that they attended. We appreciate their time too.
We have quite a few on here that have said they want to make an appointment. I've been sharing forward the office phone number back to them personally as they've posted questions and comments. So again, thank you everyone for joining us. It's been a pleasure having you. And you can look for our Wednesday wellness events every month on our IHA Cares website. Have a great night.
Thank you. Good night.
Good night.